Good afternoon, everyone. This is Kevin McGinnis for the Community Paramedicine Insights Forum of June 2018, sponsored by the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. I'm here with my partner, Gary Wingrove, to bring you this month's session. We are pleased to have with us the Division Chief of EMS for the Crawfordsville Fire Department in Indiana, Paul Miller, who has some some extensive and unique experience in community paramedicine, programs that they have tried now over the years, and he is going to share those with us today. We will be also having a session in July, and we'll look forward to having you all back for that as well on the same Monday, the third Monday of the month at 3 p.m. Eastern Time. So, without further ado, let me turn this over to Paul Miller, Division Chief of EMS for the Crawfordsville, Indiana Fire Department. Paul, thanks for joining us.
Hi, thank you very much for having me, the invitation, and this is a great opportunity. I hope everyone can see a little value in maybe a different approach to community paramedicine and offer some insight on what's going on. So we started down the approach with community paramedicine in 2013, and being a little naive in how long I thought it was going to take with relatively no hurdles, it definitely took some different paths. So we tried creating a shared valued approach towards economic development with our creation of community paramedicine. So we did a little research in planning prior to addressing our hospital president in different opportunities we thought we could collaboratively serve our community. So in some of our early readings, we looked at some of the Harvard studies along with the creation of shared value. And some of the things that we found that would be interesting and found to be good not only from the cities and the elected politicians' perspective, but our CFO and COO of the hospital is building a stronger community, inclusion, and really identifying the gaps in care. And everything that we've seen through shared value, it seems to be outside businesses are more productive and show higher earning potential with building a stronger and healthier workforce. So that's what we set out to do in going down this path. So some of the things, since I was appointed to my position in 2013, I was allowed through my mayor at the time and my fire chief to kind of take over the EMS division and make it our own. And at that point, we were one of the lower earning fire departments for firefighter paramedics in our area, and we had very little opportunity for professional development. So some of the things that we started to create was tactical EMS, community paramedicine, and a lot of the things you would typically expect a fire department to do, while we were initially looking at just lowering some of our call volumes through community paramedicine, because we really didn't need any more work to do. We were busy enough as it is with nearly 3,800 calls out of 2 stations. We thought community paramedicine would be one of those solutions. Little background, we're a pretty rural community. We are the only city in our county, and we essentially provide 80 to 90% of all emergency services, as far as ALS transports and stuff like that. And then we have good working relationships with our volunteer community and private EMS community as well. But definitely we have identified through community needs assessment at the hospital level, the state level, and the county level, tons of gaps in care and opportunities for better partnerships. So we are partnering with Franciscan Health. which is one of the larger faith-based hospitals, definitely in our area, and ton of opportunities to be able to get some professional development, education, oversight, and access to some clinical care, and really good opportunities for the state to do some data mining, which the hospital has opened up their databases for, to kind of create this program. So rural and underserved areas, we feel that our community is a snapshot of any rural community in America, and a great opportunity to pilot some of our care plans and initiatives. So social determinants of health have been really important when we're looking at any kind of health system that it's going down, trying to put one of these initiatives forward with community paramedicine. Value-based purchasing, everything that they're looking at is with the social determinants of health, whether it's food insecurity, transportation, access to care issues. They have huge impacts on how people manage their health. Access to care in most areas, especially ours, is very difficult, whether it's transportation or access to physicians. Right now in our area, physician to patient ratio is listed on the state's website at 2,500 to 1. But, you know, when we really dived into the numbers, we saw a lot of the physicians that were still licensed in our area hadn't practiced for many years, really jumping those numbers up even more. So this is the biggest thing. When we started working with the State Department of Health and trying to prepare different initiatives for us, we saw that 30% of the total healthcare spend is wasted in unnecessary services. That's the biggest concern right now for all of us when we're looking at CMS, Medicare, Medicaid being unfundable past 2026. So without solutions like community paramedicine, I think all of us are in trouble. Another thing, 60% of the total spend can be directly accounted for or changed through changing the social determinants of health and coordinating care, centering the care, and managing their care more efficiently and effectively. And that's essentially what most healthcare systems are trying to do with ACOs and other programs. This is what we thought we were going to be able to affect initially. We took a couple different paths, and I'll get into that. But we really thought we were reading in 2013 what Colorado was doing, what other programs around the country were doing with loyal customers, and we thought we were going to be able to avert some of our 911 call volumes to allow our guys more downtime to be prepared, do their training, do whatever they needed to do. A neighboring county right next to us was really good with presenting these numbers and attributing the cost of care with it. They did a white paper for the state, and we did see the same thing. You know, 5% of our loyal customers are really accounting for 50% of the total cost. So one of the things that we were looking at doing was really trying to model programs off effective home health programs already in our area, working with our ACO nurses and seeing what was effective for them. And one of the tools that we saw that people could use to help manage their care and make behavioral changes was motivational interviewing, brief action planning. So we set out to partner with CCMI. It's a company that utilizes and trains people in brief action planning. Since we thought our care plans were going to be a little bit shorter, brief action planning, 2-week models is what fit our system the best. Pretty quick and easy program to utilize and initiate. It's about a 6-hour certification course, And what it really does, instead of when somebody with heart failure or any other chronic disease goes into the physician's office, they're immediately met by what they have to quit doing, how they have to change pretty much a lifetime of learned behaviors immediately. Quit smoking, quit drinking, eat right, start to exercise. What brief action planning does is allows the provider, the community paramedic, to sit down with the patient and really see what their health care goals are. Where do they want to be at through a series of questions? And, you know, is there anything that they would like to do for their whole health over the next couple weeks would be the first question. And how confident do they feel about carrying out that health care plan from a scale of 0 to 10? You know, and after assessing where they're at, you know, we go ahead and ask them, what would be helpful to help you stay on track? And by doing that, we're building a relationship and helping them become more accountable with setting their goals. So far, it has been really effective, and when we get to our numbers, we'll be able to show you that. So Healthy People 2020. I've been a firefighter for over 20 years. Data, analytics, metrics, measures, that's really not in my background. So when we're looking at establishing our programs and our different initiatives, when we're looking at how are we going to prove the effectiveness, whether it's on the social side or the economic side, this is a great place to start. When you have that community needs assessment in hand, attach it to this and see what evidence-based programs are out there, how they're succeeding, and what kind of data they're collecting. So through community paramedicine, understand almost everyone or everybody on here has a really good understanding of what community paramedicine can offer. In our area, in Indiana, we have an unlimited right to practice under the care of a physician. So in our area, we have been working as physician extenders in our home visits. We do a lot of wellness and health initiatives, health screenings. We're looking at opportunities even to be working with the wellness, the 65 and older wellness visits in the office. We think that has a lot of opportunity for us to be seen in a different professional environment, direct oversight from the physician, and to help patients connect with their primary care physicians, and building good relationships. So we work as health educators. We are able to provide immunizations. If they do not receive their flu or pneumonia vaccinations in the home, we can assist, or in their admission, we can assist with that in the home. Right now, we are working in chronic disease management, partnering with the hospital on 4 out of the top 5 indicators that they are receiving penalties on for readmissions. We're able to access a lot of different healthcare options because we are fully integrated into the hospital. We align right with our ACO, so we have access into Epic. So all of our community paramedics can view the physician's notes, the cardiology notes, and all of our physicians are able to see the care plans that we develop with the physicians in the primary care right within Epic. So that's kind of unique. This is one of the big things that we have been able to have a direct impact on with direct feedback from the physicians is physician burnout. Not being able to manage their care, with having to be a number instead of being able to provide long-term care, with being under the scrutiny of RVUs and only having limited time in the office to spend with their patients, typically 15 to 20 minutes. They can make sure that patient-centered care is there and they're providing a higher level of care to release some of the burden that they may have that affects the burnout. So we have received great support from our physicians in our area to continue our services and grow them. So when we started partnering with the hospital, with our county health department and our state health department, we jumped in and started looking at our community needs assessment. And we found that, our healthcare ranking out of our 92 counties was poor at best, 56 out of 92. Access to care more than doubles the national average. We know that to actually be a lot higher than that. And then we saw a lot on the OB side of things, many gaps in care. Teenage birth rates were extremely high. Teenage suicides from 10 to 24 are off the charts in our area. And we're at high risk of opioid use. But none of this was going into what our initial program was. And everything kind of goes down to follow the dollar. So there were no penalties in these areas. So we had to partner with our healthcare system, bring all of our community partners and politicians into the same room and see what would be most beneficial to everyone to start addressing some of the healthcare needs for our community, and how we really make a better community that people want to move to and grow old in and be invested in. So our first initiative was actually in heart failure, and it was probably the one that had at the time the most abundant amounts of information. So there was heart failure programs all around the country, and we were able to review their programs, what was listed online, work with our physicians and our nurses to be able to create our own and make something that would work for our program, because I'm sure everyone's heard, if you've seen one community paramedic program, you've seen one community paramedic program. So the triple aim was what we were trying to affect at this time, improving the patient's family experience, access to care, and filling the gaps in care to allow our seniors to age in place while assisting the hospital in reducing the 30-day readmission for heart failure patients. And the big thing for me, I have a picture of my father on there. This was the piece of the program that was so enticing about community paramedicine to me. I grew up in Flint, Michigan. I've moved to Crawfordsville, Indiana, going on 20 years ago. And my parents, after retirement, moved a little bit further up north, spacing us out nearly 7 hours. And they lived in a very rural community, and access to care was definitely an issue. My parents had multiple chronic illnesses. That wasn't very well managed, and I thought, what a better opportunity to serve your community and have a far greater touch in emergency services than that 5-minute transport, to where it doesn't always feel like you're making the biggest difference. I was able to get the okay from the mayor and kind of move on it. So I also had an abundance of qualified paramedics that wanted to go down this path and vision with me. John Toller is one of our paramedics that started this journey with us and had over 27 years of experience in fire, in EMS, worked in the ER. He was an officer on an engine company at a slower station, but just wanted a little bit more. He agreed to take the initial training, which we set up through Hennepin College in Minnesota. It seemed to be the gold standard of what we could find. Completed everything and was really doing it for the right reasons. He's got a huge heart. And this is what we were looking at. We knew that we couldn't use our brand new paramedics to do this level of care, at least not initially, not serving with the customer service model that we would expect. This is what the hospital was able to open up to us. Pretty much every clinical area that we had asked for, we had got. Working hand in hand with all physicians, we all had surveys that had to be completed in each clinical area by the physician, and they were just fantastic partners in assuring all this was getting done. This picture just kind of goes again with the classroom portion with Hennepin College, but it was a unique opportunity. Me and the ACO manager were able to present at the UCLA Pre-Hospital Care Forum, and they accepted our abstract presentation. We won Best Presenters for our heart failure program, but this is where we had an opportunity to actually meet them in person, so I just kind of like to focus on that. So here's where we're at right now, and the different initiatives that we plan on rolling out. Our first one, the State Heart Failure Project, really opened up a lot of doors for us. We were able to show great reductions in utilization of services, pre-enrollment to post-graduation. What we were doing was we were looking at how our heart failure patients in our community that were discharged were receiving services, were falling into the gaps. When we looked at the hospital data, they were at 24% readmissions in our rural area. So obviously there was opportunity. Most all of them did not receive home health. The burden that's placed on the caregiver, which is typically the spouse, is overwhelming, especially when they do not have a background in nursing or anything else, being able to connect with services and now manage their care, new medications. So when we were able to show good success, I think initially at the end of our pilot we were able to reduce ER admissions, observation admissions, and inpatient admissions by 93%. We knew we had something, and our hospital was a lot more willing to partner and initiate different services, as well as the state with funding. So that's when we evolved in November to chronic disease management. Almost every one of our patients, if not every one of our patients, had multiple comorbidities in mental health with depression that came from maybe social isolation, but diabetes, which ended up being our number one area for needing addressed in our area through the community needs assessment was diabetes management. But COPD, pneumonia was also in there. And then we constructed, and I'll speak on each of these, our prenatal and postpartum program, which we call Project Swaddle, a falls program, and an overdose response or a substance abuse disorder program that I'll touch on. So this is where we receive our referrals from. The ACO, the emergency department, primary care, health and specialty services, and we're starting to receive 911 follow-ups with our own paramedics. But the way it works is when we receive a referral, either from the specialty care, the Indiana Heart Physicians Network, or primary care, that is reviewed by our ACO nurse and our community paramedic. We make sure that there is no duplication in services, and we also want to make sure that they don't qualify for any home health. And that was one of our best partnerships that we could have got, was the connection with our nursing staff. The support from our nurses in this community has been overwhelming, especially with home health and hospice, when we were able to do ride-alongs. And our medics were really invested in what they had to say and learn from our nurses. And being a small community, we have a lot of personal relationships. A lot of the firefighters are married to nurses. A lot of them have moonlight in the ER for over 20 years. So that connection was there. I don't know if it's there in every community, but that was definitely something that was meaningful to us. All of our nurses that are involved with the care with the ACO and our physicians, staff all of our patients weekly. All of our physicians that are assigned to the patient sign off on the notes every week. So there's a lot of oversight in the care. So with our heart failure program, probably not completely unique to anything that you would be able to reference out there anywhere in the country. You know, we're looking at any of the chronic diseases that caused the admittance. A lot of our patients, because we're not able to manage their own care, because of the social determinants of health that they had not been identified or addressed, they had become high utilizers, almost every one of them. But what we've been able to do is follow up with them within 24 to 48 hours, do the home safety assessment, the med rec, which has been important, and able to do some dietary education and assessment. And what we have found to be really beneficial is how we've incorporated telehealth in it. So all of our patients receive the following devices: Bluetooth, blood pressure cuff, blood sugar checks, and then they're also given activity trackers, pulse oximeters, thermometers, and iPads. With those iPads, we're really looking at decreasing that social isolation. We've been able to put Skype and FaceTime on these devices to help them connect with friends and family that they may not have seen in quite some time. And they can also get on their own health charts and review them and see their patient notes and different things for their instructions. But what's unique about it is our medics can see their scales and their weights go up and down live through their own devices. They can share that with their friends and family that may want to assist them with keeping on track with their care plans. So we think that's been pretty important. We're also able to provide iStats. Now, I know every state, because of the scope of practice, are unable to do the iStats. We do not charge for them. It's not an office charge. But what it does is reduce the number of times that they need to go in for just a lab draw when we can assist with managing that in the home. And it helps our physician if we need to do any kind of medication adjustments in the field, that we're able to do that because we have those lab values. So here's some of our numbers. While not everyone that has referred to our program has enrolled in our program, and some of our patients have been a little bit younger, still had work, didn't feel they had time for the visits and stuff like that. And a lot of the separation in between discharge from the hospital to first visit, that's all based on the patients. When we receive that referral, we do call them within 24 to 48 hours. Typically, it's been less than 2 days. But a lot of times, our patients have different things going on, which seems weird. Our average enrollment age for our chronic disease program is at 77 right now. But still, with weekends coming in, they pick their appointments. And it's been out to 7.6 days. And you can see how many total visits. This is an old, some older data from the beginning of 2018, just kind of rounded out our heart failure and chronic disease visits. And you can see that we're able to avert some of our ED visits simply by a phone call. They have questions, they're not sure about their medications, they have some new swelling, and our community paramedics are able to answer them over the phone, do an unscheduled visit, what it may be, and kind of avert that. So we've been able to have some decent impacts. It's kind of subjectional on how you're tracking ER avoidance, readmittance avoidance, but it is scrutinized by our providers, the ACO, some of our executives, care coordinators, and stuff like that. It's not just simply me stating it. This is what the hospital has been providing us as far as data. And utilization, prior to some of these services being enrolled, we had one loyal customer that had utilized services 90-something times prior to enrolling, 1 year prior to enrolling into our community paramedic program for chronic disease, and we were able to decrease that by 50-something%. So while it may not be 100%, there is definitely merit to the motivational interviewing and providing this patient-centered care. So with one of our partners, with QSource is a quality team that works with Medicare. They look at providing evidence-based best practice models. With them reviewing our data, and this isn't me doing it, this is them having access to our healthcare system and being able to do some data mining. They've been able to put some numbers together that actually show what avoidable charges have been tracked through our relatively small program, less than 40 patients. And what this does is also highlights, decrease in services. We've been very successful. AHA recommends all people that have been discharged from a hospital for heart failure receive follow-up visits with their primary care within 7 days. Because access to care is an issue, being able to get that first appointment after discharge, most of our patients were seeing their physicians when the readmission rates were at 24%, 14 to 21 days post-discharge. Obviously, that backed up AHA's numbers. For our community paramedic patients that were enrolled with our program, we were able to push first in-office visits out 21 to 30 days and still have 0 readmissions. And you can obviously see the advantage of having a community paramedic with the observation stays. The lows have dropped as well. So the overall reduction from pre-enrollment being 12 months prior to enrollment. Some of the programs that we saw there around the country were using 6 months, 3 months. We thought 1 year would be a good snapshot of what we were looking at and really painting a clear picture. So the big number, which this is even changed as of Friday, still has a significant impact in reducing the cost of care and being able to attract more investment from our health system. So this had more than a 4-to-1 return for our health system directly. This doesn't even impact the long-term cost of care with these patients. There's definitely more charges that could be assumed with this, as far as occupational therapy, people that would need to potentially transition to extended care facilities, different surgical stays, infections, and different things, and the length of stay. Being able to reduce the length of stay with the health system would definitely have more of a financial impact as this goes forward. Again, this is just focusing on some of the uniqueness of our program, again, with the telehealth and utilizing brief action planning. We utilize the STEADY CDC program. It assists us with assessing their mobility and referring off to potentially silver sneakers or other fitness programs. We have some water aerobics that we're able to refer at a 0 charge to our patients to where it helps them build strength. We know for every week that they may be in the hospital has significant impacts on their strength, flexibility, and stuff like that. So the one program of ours, an initiative of ours, that has probably gained the most attention in our area and around the state is with our prenatal and postpartum program. Prior to me being appointed to my position, our hospital, which is right here in town, removed their OB unit. So all the moms in our area, if they were wanting birthing classes, the MAs, lactation, anything connected to OB services, it was a 45-minute drive to where they would deliver. Now, that's only if they deliver with our own health system, but there's no other health system closer than 45 minutes for us. And if it's a high-risk pregnancy, it's a little bit further. So we looked at this, and partnering with our Women's Resource Center, I was really trying to connect them with nurse-family partnership. I'd had some good success in writing grants, and I thought this was a good opportunity to be a community partner and assist with grant funding for nurse-family partnership, hoping up another area to provide services. And when that really wasn't going too well, I kind of looked at what the nurse-family partnership was able to provide and thought we could do the same thing to buy our moms some time to make sure that they were getting the care that they deserved. The hospital definitely wanted to partner with us on this. It was a good opportunity for them to connect with the OB services in our area and to be able to bring in new families to the primary care physicians. So that's what we did. A lot of what we were doing early on was trying to see what was having impacts on infant mortality in our area. At the same time, our governor took a look at infant mortality for the state of Indiana, which is poor at best. And we broke it down. We looked again at Healthy People 2020. We looked at our community needs assessment, and we saw how we could fit in. Brought in OB, nurses, and physicians to really kind of construct this program with us. And everything that we've done has been through collaborative efforts. And there's been such an abundance of resources given to us. I think that's essentially why we've been able to show such good success. In our area, most of the things that were affecting the infant mortality, preterm deliveries, low birth weights, have been due to a couple issues with our smoking rate among moms and pregnant moms, domestic violence, and drug use. And when we're looking at this is how we started constructing our program, but it has definitely evolved from what we thought we were going to do and what our patients were going to look like to what it is now. So some of the quick facts that I just touched on, this was the governor's initiative, and since we are partnering so closely with the State Department of Health, this is where we were looking at constructing our program and different initiatives and things that we could do to affect each one of these. So we told the state early on that we were going to improve the overall health for women of childbearing age, promote early access to prenatal care. Initially, when we started on this, I think 66% of our moms in our area were not receiving adequate prenatal care, and it was early or late into the first trimester, early second semester. As we really started partnering, even prior to implementing our community paramedic program with our Women's Resource Center, we started to see significant drops in the access to prenatal care early on. The goal is 12 weeks with Healthy People 2020. They were able to, even prior to enrolling us, down to 8 weeks. So that was a huge success by just starting to collaborate and get people at the table to have these conversations. We sent all of our paramedics to some really non-traditional classes. We did partner with the state on safe sleep education. Our paramedics are trained to deliver that care in the home. We do car seat technician. These were some of the easy things that we're able to do, but some of the outside the box thoughts that we're able to do and be able to provide training in was lactation education, Lamaze education, and certification, and smoking cessation. And we've been able to partner effectively in all these areas to receive that kind of certification. And one of our biggest successes, I think, was being able to partner with Baby and Me Tobacco Free to be able to provide the nicotine testing and diaper vouchers, which incentivizes our moms to stay smoke and tobacco free. Our next one that we hope to have in some shape and form by the end of the summer really touched home on many levels with our department. Now this, while we're just the 9th most at risk, when you see this it looks like we're 9th worst in the state. We are not, but we're definitely at risk, and we wanted to show a lot of leadership and progression in addressing this issue. So a lot of the dollars in this was associated with opioids, and now we have transitioned it to substance abuse disorder. We've seen this correlate right with the mental health and our suicide rates as well. That we knew we could get the right people through our collaborations that we had already built in community paramedicine and go down this path. We've had family members within our own department be touched by this, and it's very personalized for us. We've had one of our kids lose their life to opioids. We've definitely had 2 more that have had battles, and they're going to be lifelong battles that for our brothers and sisters, we want to be able to have the answers for them, but the rest of our community, because this goes against, crosses all social and economic boundaries. Everyone is touched by this, rich, poor, it doesn't matter, professional, whatever it is. We've been able to put services in place by partnerships with all of our mental health facilities are at the table, our superior court judge, our prosecutor, our jails, and our county health department. We're working to be able to employ peer recovery coaches to where we're able to provide care immediately at the overdose, whether it's an opioid or any kind of substance abuse. We're working on MOUs to where we can transport from the field to an inpatient facility. We've kind of stolen this from the Hamilton, well, we kind of haven't. We did. We've been partnering with Hamilton County Opioid Coalition in the Cincinnati area to see what they were doing with their programs. Columbus Fire Department in Ohio, they're just doing amazing things in Ohio and related to patient-centered care in overdoses. And Indianapolis as well, IEMS has been able to put together care programs to make sure that people are given the opportunities to be successful. And that's what it's all about, treating it like a disease that it is, and giving them another opportunity, just one more day to make that change. So providing wraparound services, harm reduction education, 24 to 48 hour follow-up. We're also working with court systems to get the drug court opportunities for decriminalization prior to being released from the jail, doing some more harm reduction education, helping them with transitional housing. IU School of Health, Fairbanks, has been really instrumental with kind of packaging this for us and working on a Grand Challenge grant directly with IU to be able to allow us to put these kind of systems in place and take care of financing it early on. Fall prevention. This is where I think 911 has the biggest opportunity to make impacts. When we look at studies from the CDC, we see that adults 65 and older have unreported falls every year. 30% of that population report having a fall in the home through surveys, and it's far, I think 60% of 85 and olders have unreported falls in the home. We know that this kind of correlates with the data we see at the fire department. Out of our 4,000 calls a year, nearly 1,000 of our calls are directly related to an injury from a fall or just a simple lift assist. Wabash College, one of our community partners, did some research and some data mining of our own EMS data and found out that if we were able to make an impact, just a small 25% impact on the number of falls by being in the home, doing the med recs, connecting them with services and stuff like that, we could potentially have a $750,000 impact. And that's just on the cost of providing the EMS care, the fire department care, and the EMS transport to the ER. That has nothing to do with skilled nursing, surgery, extended care facilities, loss of wages, mortality, or anything like that. So this is where we're heading with our next initiative, and we think we have the biggest opportunity to have impacts on the health and wellness of our community by allowing our seniors to age in place. So how we envision it and how we're building it with Q-Source, the state, and Purdue University's Health and Human Sciences program is we would have a community paramedic respond on the call. If they need to be transported, they would assist with the transport, do the 24 to 48 hour follow-up. As long as they weren't admitted for anything or any surgical stays, we would also work with case management at discharge to help that patient transition safely in the home and get the services that they need, so we can assure that they're not being readmitted for any kind of infections or PEs. Help with the home safety check, med rec. The home safety check, we've been able to partner with our Council on Aging, and it's Area 4 for us, to really put some strong services in place and help them with that patient navigation that needs to be there, connecting them with primary care and stuff like that. So the big thing we're always asked is, how much do all these services cost? What's the increased tax burden to the fire department and the people in our community? And right now, we have zero charges associated with our program. Our community paramedicine program runs as a non-for-profit, so if you're in an area that has the ACO, they're very familiar with contracts, subscription services, and this pay-for-performance that everything's supposed to be moving towards. And that's what we've been able to do. We're able to secure some of our initial capital investment from our community foundation that saw a value and an opportunity to partner with us. Indiana Rural Health Association assisted us with telehealth early on. The Indiana State Department of Health for chronic disease management and rural health has been our #1 advocate, and Franciscan Health pays for the employees at the end of all the State Department initiatives in grant funding. And we're really seeing a lot more opportunities that potentially may come from this. Our Medicaid in Indiana has just approved community health workers. Really looking at going forth with what Minnesota has been able to do and paving the way for that for us in this state. So when I speak of our community partners, the biggest thing and opportunity that we had, I think, to be successful is surrounding ourselves with people that are good in their areas, breaking down silos, being able to collaborate and partner and take in their expertise. We had access to 3 different higher learning institutions, with world-class researchers, and you start to build those collaborations, and that gets a lot of attention and recognition to where they may not want me doing their data, but they will trust in Purdue and IU and Wabash College collecting that data and proving it, knowing that there's some credence in what they have to say. Wabash College is a Princeton top 5 academic college, so this has been very, very good for our program. Q-Source, again, a portion of Adam Alliance, they report directly to Medicare. They're the ones that are overseeing the data collection. They're building with us and all of our partners a package, a modeled program that can be replicated in the other counties for falls prevention. They're also working with us to be able to replicate portions of our chronic disease program and our substance abuse program. So whatever in our OB, so that anyone, based on their community needs assessment for the state of Indiana, would have access to this and be able to make it their own based on their partners and resources in their community. And again, Franciscan Health and everyone else that's in there. That was kind of a down and dirty. Got over definitely a little bit quicker than I anticipated, as I kind of breezed through it, but I'd be happy to take any kind of questions regarding our program, our partnerships, how we're looking at sustaining this long term and diversifying our payment models. I think right now, as I have meetings with our state health commissioners this week and our state representatives on the Ways and Means Committee, we know that our payment model for community health workers is not sustainable, but we think we have a lot of opportunity with our partnership with Q-Source and having direct access to some contacts with Medicare, that we do see that this is going to be a reimbursable program. I know we've had multiple conversations with 2 of the top health insurers on the national level for reimbursement and what they're looking at with subscriptions and stuff like that. I know they've partnered with other programs, and I see that being there. Another thing that we're looking at that's kind of outside of the box is social bonding and creating that on a state level to where there is financial incentive for investing in programs like these. It would be like any other kind of bond, but there's definitely good return and opportunities with them. Right now, I see the question on there is how many CPs do our program have? We have 7 trained. We have 3 outreach vehicles. 2 are full-time, and we are anticipating all 7 working full-time by the end of this year. 3 of them have been additions to our shifts. So our current staffing, we're a pretty small department, is at 14. We're going to increase staffing. We anticipate increasing staffing to 15. Those 3 that will be staffing the 3 shifts 24/7 will focus in the areas of substance abuse disorder and falls. Everyone else is on 8-hour shifts, 8 to 5, although they work a lot more than they're supposed to, but they have seen our medics. The biggest thing I get from our medics that have went down this path and what we've been able to do with our mayor is really create a new level of career satisfaction. And we've been able to extend careers, and we've offered more opportunities to where if a firefighter paramedic chooses to retire, we're going to allow them to keep their same position so they can receive insurance and provide care in community paramedicine. So they're able to, in essence, double dip, receive their retirement, and then work on a different pension system in delivering care in community paramedicine. So it's been fantastic in professionalism, job growth, and stuff like that for our department. And we do only have providers. Oh, I'm sorry, go ahead.
That's okay. I was just going to, please, can you state that question that they've typed in?
Yeah, so currently we only have advanced directives and paramedics providing this level of care, although we are beginning to partner with the state in developing BLS models in which may be replicated in different communities. Our community, we require all of our firefighters to become paramedics within 3 years of employment. So that's really all we have. And until they get 5 years experience as a paramedic, we don't really even think they have all the necessary skills to be able to provide this level of care. Although many systems I have seen be very successful with 2 years and less experience. Each organization's different. That's the great thing about community paramedicine. Whether you're private, fire-based, or hospital-based, you know your community best, and you know how to best serve them, and what your business model may look like in your area may not necessarily work in mine. We did see when we were partnering with home health that they were having a lot of difficulties accessing homes and patients. They wouldn't sign up for services because a lot of times, you know, with the women in our programs, they were worried about having their hair done, the house cleaned for when a nurse came in, because of the judgment, the fear of judgment. With the paramedics, you know, they're used to seeing them in the home. They're used to seeing them with the curlers in their bathrobes, and they don't get dialed up for us. They just know that they trust in us to provide that level of care, and they welcome us into the home. And they really appreciate that, you know, we're willing to spend time with them and listen to their concerns and review their care plans with them and go through their discharge paperwork and review medication. So we've really seen a lot of support. But we've done a lot of outreach. I think I've spoken at every senior meeting, whether it's faith-based, community-based, Rotary, Kiwanis, Lunch and Learn, whatever it is I've been at to really make sure our community knows what kind of care we're trying to provide them. And really, now that we've been able to do the OB program, we feel like we have systems in place to attract professionals, businesses, when they're starting a family and transitioning them all the way through the end stages of life to where they're able to age in place. And even bring in family members and older adults back to live with their kids, we're able to help with that kind of care that they trust and respect.
Well, Paul, that was a wonderful presentation. I'm going to ask Gary to take everybody off of mute. And while he's doing that, can you give us a sense for what the physical or the process is of a referral?
The conference has been unmuted.
When the referrals come from either primary care or from one of the other sources you noted, who do they go to? Who do they call to get a community paramedic?
Depends on where they come from. So since we are in Epic, the referral source is a message right within Epic. So case management can hit on that referral tab right in the ER or at discharge, and it's going to spark them. If they're just at risk of being admitted for any of the disease processes, then the primary care physician or the cardiologist specialty care does the referral right within Epic. prior to that, the nurse and the paramedic sit down together. They look at the chart to make sure that it is a good candidate, and then they do the phone call to the patient. We've seen a real influx of people coming back to this health system and not using others, whether because we have opportunities since we're a rural community. They could drive the 45 minutes and go anywhere, in which they did, especially when they closed the OB unit. And now we see them really drawing patients back into it. So the hospital is seeing multiple benefits of this, diversifying their patient panel, bringing people into their primary care offices and stuff like that. And then the cost avoidance, which has helped with their, I don't believe they're receiving any penalties in any of the 4 areas.
Is there any chance of, since they're getting such benefits, of underwriting some of the cost if you're going to 7 full-time CPs?
Yeah, so actually as a partnership, our city is now going to, it's a different tax, but they are going to pay for 1 full-time to be a good community partner with our hospital, and our hospital is paying for 2. Through the state, until we were able to get with CMS and work through some of this, or even at the state level, whether it's through Medicaid or social bonding, fund these initiatives so that we can create it and we can grow it. I reach out to multiple health systems. We've offered opportunities. We will be going to Cincinnati Fire and teaching brief action planning to their providers over there that are working with their quick response crews. We offer ride-alongs at our department to really grow this. So if anyone wanted to see how we deliver care, OB, pre or postnatal, chronic disease, whatever it is, just see how we're charting. We offer those opportunities, and we've been working with multiple hospitals all around the state and providing them opportunities.
That's great. Super. Okay, everybody's unmute. Everybody online is unmuted. Are there any questions for Paul?
Now, Chrissy, since you are from Michigan, I'm going to have to allow you that opportunity. I still have a ton of family and friends that work in EMS in Michigan, and if this could be an opportunity that you could grow it in your community, we'd love to have you.
Thank you.
As long as you're a Michigan fan.
Okay, do we have any further questions from the audience?
I'm really excited to see Dr. Swayze on there. I've listened to him speak so many times. He is one of the most motivating speakers I've been around.
Indeed.
I'm humbled, Chief. You did a great job. Keep up the good work.
Thank you.
All right. Well, I think we'll call this a day. And Chief Paul Miller, thank you very much for joining us today. We greatly appreciate your sharing this wide breadth of experience that you all have had in Crawfordsville. And we wish you luck with your future programs. And I imagine we'll probably hear from you again on this program sometime in the next year to follow up on some of your data that you're developing.
Yeah, I'd really like to do it with our partners from Purdue University and QSource to where they could dive into the data and paint that picture that the data is providing more so than our initiatives, so they could break it down to show the true value. Super.
All right. Well, very good. And I want to thank everybody who joined us today. My partner in crime, Gary Wingrove, for the technology involved, and the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS for supporting our programming. We will be back on July 16th at 3 p.m. with another Community Paramedicine Insights Forum. Thank you, and I hope everybody has a great week.